and had gone off in the desert for 5 years, you might come back and say, what is this igG4 related disease? Never heard of such a thing. I never learned of it in my fellowship. And it's one of the hottest topics now. The fellows certainly, they're always on the lookout for igG4 related disease. So we've asked Dr. Marty Bergman to review all of the evidence and catch us up on this important topic. Marty?
Thank you, Artie. For the folks in the back, there are lots of seats up in the front. I mean, you don't have to sit way in the back. First of all, a show of hands. How many people here have treated or have been involved in the treatment of somebody with igG4 related disease? All right. Well, having reviewed the literature, I'd like to say that if you haven't seen a patient yet, either you're not in practice much or you've missed it. On the other hand, if you're seeing a lot of patients with igG4 related disease, you're probably overdiagnosing it. So it's something we do have to consider, and something I hope to present as we go along. So let's go with a little bit of history. I like history. I think it helps us put things in perspective. We'll go back to 1892 when Dr. Mikulec, who was an otolaryngologist, presented a monograph of this man. I think that's an important feature. But a gentleman who had lacrimal and parotid swelling, as well as sicca symptoms, dry mouth, dry eyes, who when biopsied had aggregates of inflammatory cells in the gland, and came up with this concept of Mikulec disease. It didn't get a lot of play at that time because by using the definition of parotid or lacrimal swelling and aggregates of lymphocytes, there was a lot of overlap with other conditions, including sarcoidosis and lymphoma. So there was a delay in trying to accept this as its a unique condition. This changed, though, in the 1920s when Sjogren, who was an ophthalmologist, presented a number of patients, mostly women in this case, who were presenting with dry eyes and keratoconjunctivitis sicca, or actually damage of the cornea. He presented this large series as part of his dissertation for his doctorate, and it was actually refused. The reviewers didn't think much of it and had him go back and further study it, and in fact, it took about 30 years before it was actually accepted as its unique condition, to the point that finally in 1953, both Morgan and Castleman accepted the diagnosis of Sjogren's syndrome and then listed Mikulec disease as a subset of Sjogren's syndrome. So now we have this one big disease, Sjogren's, and we have subsets. We have a Mikulec disease. And in fact, that training kept on until about the turn of the century. So most of us who are up on the stage, we were trained that Mikulec syndrome and Sjogren's were basically overlapping conditions. But the Japanese started noticing something in their patients, and it started off, first of all, with one of the lower bullets, which is they were seeing patients who were having autoimmune pancreatitis. Patients were coming in, no obvious cause, autoimmune pancreatitis, and then they were noticing these other features that were looking just like Sjogren's syndrome. There were certain things that were very interesting that made it different, however. First is, despite the fact that they may have had massive swelling of their parotid glands and lacrimal glands and submandibular glands, their xerostomia was actually relatively mild, and so was their xerophthalmia. They did not have the keratoconjunctivitis sicca. They didn't have this damage. And furthermore, when they treated these patients, they didn't have the same problem with treating them. Sjogren's syndrome is notoriously difficult to treat. I think we've all heard that. There was a question earlier about rituximab in the treatment of Sjogren's syndrome. We know how difficult this disease is to treat, whereas they found that these patients were very responsive, at least in the short term, to steroids. The other thing I mentioned earlier, but it's a very important feature when you think of autoimmune diseases, which is the male and female predominance was very similar. And when we were able to do more extensive antibodies, they found ANA, SSA, SSB titers were not necessarily that important. Finally, they were eventually looking at igG4, and they started to notice that there was this role of igG4 and igG4-bearing plasmacytes in the condition, and this made them start thinking, maybe we're dealing with a different disease. So the Japanese took this further, and they started to say, you know, we're seeing this. And when we look at patients with Mikulec disease, we're starting to see definite prevalence of igG4. And finally, after a lot of wrangling, in 2010, the syndrome became identified and was named igG4-related disease, or igG4-RD. So this is a relatively, actually not relative, this is a very new condition. And that's what makes it so hot and why everybody is looking for it. And I'm as guilty as the next, trying to find it in every patient I have who has Zika or comes in with swollen anything. The success rate that I've had in my practice has not been so great in finding it. This, however, is the hallmark of the disease. If we look at the left-hand side versus the right-hand side, these are both parotid biopsies, and you can see infiltrates in both of them, but when you stain the plasmacytes for igG4, you can see the marked staining on the left-hand side with the patients who have McCulloch's disease. Whereas patients with Sjogren's syndrome, there's virtually none. They're both very inflammatory, but there's a very big difference in the presentation and how they appear on biopsy. So the Japanese have come up with this condition, and they have presented this long list of different features. I actually love this picture that they came up with, where you look at the different places where the disease can occur. Thyroid disease is one of the major features. You can see Kuttner's, Hashimoto's, and Riedel's thyroiditis. Autoimmune hypophysitis is something that's seen, as well as orbital pseudotumor. Lungs can be involved, both in terms of nodules and other features like the nodules, but also interstitial fibrosis. Pancreatitis is one of the major features, and it's one of the things that really should make you start thinking that you might be dealing with this condition. Sclerosing cholangitis has been seen, renal involvement has been involved, aneurysms, particularly eosinophilic aneurysms, and that's going to be important when we start talking about the etiology of this disease because of how this particular antibody, the igG4, interacts with the Th2 system. We can also see prostatitis, pseudolymphomas of the skin, and also Rosai-Dorfman, which I've seen now a couple times, but also independent of igG4 disease. When we talk about igG4, however, we really need to understand the biology of the molecule itself. This is a fascinating molecule. Of the 4 subtypes of IgG, this is the least common. Its variability from individual to individual is huge, going from 3 to 6% of the total IgG titers, but generally the normal levels are less than 1.4 grams per liter. So this is a low-level antibody when we talk about IgGs, but it's a fascinating molecule in that it doesn't bind complement. It also has this very promiscuous behavior of exchanging its heavy change between molecules, which I'll show shortly. But this allows for this production of very weird asymmetric antibodies that are unable to bind true antigens and thus are unable to lead to a classic immunologic response. What it can do, though, is it can bind the Fc portions of IgGs, as opposed to cryoglobulins or rheumatoid factors, which bind the variable change. This comes from the bottom and hits the Fc portion. So they will behave as rheumatoid factors, but they're less likely to form immune complexes. We can see that because of the way they interact, they have a Th2 response, and they do have sort of this allergic response. So you'll see elevated levels of IgG, you can see elevated levels of eosinophilia. Patients who have this this condition will also have other immunologic type diseases like asthma, rashes, hives, wheezing, and an allergic phenomenon. But the other thing that's becoming somewhat interesting is the fact that this particular IgG may actually be anti-immunogenic. So rather than pathogenic, it may be anti-immunogenic. This is a cartoon showing what is actually happening. I want you to focus on this area here and these 3 here. So you produce these antibodies, and you can see these disulfide bonds in the heavy chains are kind of weak. So it allows for this exchange, and you can get these bizarre formations where the Fcs come together backwards because you're binding, and you get these nonspecific and asymmetric molecules that are unable to have the dual hit on the FAB section, so you're unable to really generate an immune response. Now, IgG4 is related directly as a pathogenic disease, as a pathogenic agent in certain diseases. George, you probably see some of these people, the pemphigus vulgaris and pemphigus foliaceus. And these target the desmoglin, one, and this is a direct response to igG4. Idiopathic membranous nephritis, as well as membranous nephritis in children, has been shown to be directly due to the effect of igG4 on the phospholipase A2 receptor in the podocytes. And finally, TTP is now believed to be an igG4-related disease, targeting with the adaptase 13, which is a metalloproteinase. These diseases, when we talk about igG4-related diseases, are excluded. So this is not considered part of the syndrome of igG4-related disease. So now let's get to the epidemiology and what makes this disease very interesting. First of all, it's a relative, compared to autoimmune diseases, this is a relative male disease. When you look at the predominance with autoimmune pancreatitis, it's 2.8 to 1 male to female, which is not what we classically see in autoimmune diseases. It also tends to be skewing somewhat older than most of our autoimmune diseases. So patients are generally older in the 50s, but it's still a rare disease, and I think we have to come up with that. Anytime we talk about this condition, we have to recommend that in Japan, we have to recognize that in Japan, it's 6% of autoimmune pancreatitis. At the Mayo Clinic, it's 11%, but if you take that number at a rate, it's 0.5 per million patients, or persons, not even patients, 0.5 per million people in Japan. This is a rare condition. Now, there does seem to be, at least in Japan and Korea, a genetic factor. We can see the DRB10405 and the DQB10401, which is seen in Japan. The DQ beta157 is seen in Korea. What that effect is, we're not entirely sure. There is, however, an interesting etiology that hasn't been proven but seems to be of interest, which is what's called bacterial mimicry and innocent bystanders. It turns out that H. pylori has a protein on its surface which has homology to a protein on pancreatic acinar cells. And it turns out that this protein is recognized by the DRB10405 in patients who have that particular gene. So there may be that these patients get affected with H. pylori, they are then recognized as protein, and then this protein is recognized on the pancreatic cells, and there's an autoimmune response as a result. But I think it always comes down to the basics. Just because something is there and in excess doesn't mean it's causative. We don't know whether or not igG4 is causing this condition, or is it an innocent bystander, or is it actually something that's down-regulating another immune signal. We just don't have a clue on that. So it's something to keep in mind. We don't know the true pathogenesis of this disease. The clinical features are very important because they're generally subacute. These patients don't come in constitutionally sick. They don't have the fevers, the chills, the night sweats, the weight loss that you would expect with a true autoimmune disease. Instead, what you find is that the disease is generally related to the presence of a mass lesion. These are big, can be very big mass lesions that have tumefactive effects. If they're up against the bone, you can get bone erosion from a pressure effect. If it's hitting a structure, it's blocking the structure, you get the symptoms from the blockade of the structure, but it's generally not symptomatic in and of itself. And because of that, when it's found, it's usually by mistake. Patient comes in for one other thing, and then we pick up the lesion as a result of going for the further studies. The most common sites are pancreatitis, or pancreas, hepatobiliary system, and then obviously the places where we can see it the most are going to be the salivary glands, the orbit, and the lymph nodes. But again, a lot of that simply has to do with a relatively asymptomatic condition and location, location, location. If it's retroperitoneal, we're not going to see it, whereas if they come in with big parotid masses, we're likely to find that out. The symptoms themselves, however, again, is due to this mass effect and is very much determined by the organ in which the mass is occurring. So let's go through this nice list of all the different organs, or many of the different organs involved, and recognize what the symptom is and then the cause. So with the thyroid gland, the patient's going to present with hypothyroidism. But that's really because they get this mass which is obliterating the thyroid. Lungs, they can get cough, dyspnea, which is due to either the interstitial fibrosis or lung masses, lung nodules. Central nervous system, they can get blockade. Most of the time, though, they're getting more endocrine-type symptoms with headaches, and this is due to the involvement of the hypophyseal area. The orbit, involves the eyes. You get pushing out of the eyes, protopsis. And again, this is due to the orbital mass, likewise for lacrimal glands. We're going down to the liver. Liver's, again, going to be more obstructive. You're going to get something that interrupts or blocks the flow of bile. So a patient may come in with jaundice, may come in with pain, but it's going to be the incidental mass that's found on a CAT scan. Skin or nodular lesions, lymph nodes, again, lymphadenopathy may be massive. Prostate salivary glands are, again, going to be more symptomatic due to blockade. Inflammatory aortitis, often with eosinophils, is something we have to always think about. And then retroperitoneal is going to generally present either as just the finding, a patient came in with nonspecific findings, came in because they were having gallbladder problems, or they were having appendicitis, or for whatever reason, and a CAT scan or other imaging was done, and by accident, a patient was found to have retroperitoneal mass. Or the other possibility is that they were having ureter or other obstruction of a viscus, and because of that, the patient had the CAT scan and we find the mass. Pancreatitis, again, is generally the place where most people think of this disease, but again, that may simply be because that's what we're being told to look for. So people are looking for it in pancreatitis, so we're finding it more in pancreatitis. It's not the only site, however, that's involved. There is nothing unique about imaging, however, about this study. It really just shows a mass. There's nothing specific. We can see the patient who is having the ophthalmologic involvement. You can see the protopsis here, and you can see the soft tissue masses there. Likewise, you can see the massive parotid swelling in this patient. You can see the parotid and the massive parotid swelling on CAT scan. I don't know about ultrasound on these patients. I'll defer to Alvin on this. When you have a patient with Sjogren's syndrome, there's a very specific change in their parotid glands. They look like Swiss cheese. They have this nice homogeneous effect, and then they have these dots, these black holes all through their parotid. I don't know if that's ever been studied. I have not seen anything published. It would be fascinating to see whether or not these lymphocytic islands show up on an ultrasound of these patients. It's just not known. Likewise, they talk about this crescent-type shape of the pancreas with the diffuse swelling and some dilatation of the ducts. But again, there is nothing unique about this picture on a CAT scan that will tell you the patient has igG4-related pancreatitis. So it's simply something that is there, something we have to be aware of, and something we have to look for. When we do a biopsy in these patients, there is a classic triad that we can look for, and this is part of the diagnostic features that are looked for in the biopsies. There are three presentations. You can see it starts generally around some kind of a hollow structure. You can see these large lymphocytic infiltrates coming in. They have both B cells and T cells. Eosinophils may be there, and when we stain them for igG4, they are positive plasmacytes. A different version is this fibrosis with what is called storiform pattern. Storiform pattern is sort of this whirly, very tumor-like, and in fact, if you were to get a biopsy of any structure and see these bizarre, weird-looking cells with a very nonspecific and very wild pattern, your first concern would be that this is a tumor. So you always have to be concerned about that. There's a lot of mimicking for tumors, but again, this is something that is concerned. And finally, the last feature is a classic venulitis, inflammatory venulitis, homogeneous type cells. Right in here is where the vein should be, the venule should have been, and now it's totally obliterated. Now, again, if I were to show you this picture, one of the things that come to mind is a granuloma, that this is sarcoidosis, and in fact, that was the problem that McCullough's had way in the beginning. But a very important feature of this is there are no giant cells involved. So if you see giant cells in this, you are not dealing with igG4-related disease. It's a feature that you simply do not see. So granulomas are not seen, even though you get these large accumulation of cells. Serologically, there are certain features that are suggestive, but not diagnosis. I started with this when we were talking about the etiology, which is igG4 seems to be elevated, and it's greater than what's felt to be the upper limit of normal, which is 1.4 grams per liter. So anything above 1.4 milligrams per liter, grams per liter is something that should make you think of this disease. However, it's a non-specific finding. And in fact, 5% of normals will have this level of igG4 and have absolutely no features of disease. The other problem with it is patients who have biliary and pancreatic tumors can have elevated levels of igG4. So you don't want to say, oh, this patient has igG4-related disease, we'll give him just some prednisone, and turns out you're missing pancreatic cancer. So the fact that your patient has an elevated level of igG4 is interesting. It may steer your direction, but should not be made as a diagnosis. And the other direction is just as important. Patients who have igG4-related disease, 30% have normal igG4 levels in their blood. So you can't make the diagnosis on serologies alone. Other nonspecific findings are going to be elevated total IgG levels, elevated IgG, because remember the Th2 responses, eosinophilia. They may or may not have sed rate elevations and C-reactive protein elevations. That's something that we always have to keep in mind. And just when you thought it was safe to go out at night, you have to also remember that 50% of these patients will have positive ANAs, and 20% will have positive rheumatoid factors, which are features of Sjogren's syndrome. So we're trying to differentiate this from Sjogren's syndrome, but a lot of the a lot of the serologic features may overlap with Sjogren's syndrome. So the question then is, how do we come up and make a diagnosis? Well, there's certain features that we can call highly suggestive, and then there are other features we can come up that are kind of suggestive. The clinical features that are highly suggestive are going to be symmetrical swelling of any glandular structure, particularly lacrimal, parotid, or submandibular. Another feature is autoimmune pancreatitis. Again, this is where it all started. Anybody who has an inflammatory pseudotumor or retroperitoneal fibrosis is something you should always think about. If a patient comes in with a RPF, you have to think, do they have this disease? And then Castleman's, which is large lymph node disease, large lymph node swelling, is something that should also trigger you to think in these terms. And if you get the blood test, if they have an elevated IgG4, certainly is going to push you. And if you do a biopsy, you want to stain it for IgG4 and IgG to see whether or not there are more than 40% of the IgG cells, IgG staining cells, more than 40% of them are staining for IgG4. This should also steer you toward that direction, but keep in mind that you also want to look for granuloma, because you should not see giant cells, you should not see granuloma, and that would be an exclusion for the diagnosis. Other features that are suggestive but not diagnosis are going to be unilateral swelling, orbital tumor, sclerosing cholangitis, prostatitis, interstitial pneumonia, and interstitial nephritis. Obviously, that's very nonspecific. I wouldn't want to make this diagnosis on that alone in anybody, seeing how we see it all the time. Likewise, thyroiditis and hypophysitis. But inflammatory aneurysms is something we probably should keep in mind, probably somewhat undiagnosed. Patient who comes in with hypergammaglobulinemia of unknown origin, low complements, elevated IgG or eosinophils, and then any obvious mass that has a tumefactive effect on other imaging should certainly steer you toward thinking about this disease. There are lots of criteria that have been proposed. There are many that are organ-specific, but seeing how it's really the Japanese who came up with the diagnosis, who really defined the disease itself, I feel that we should give them their props and use their comprehensive clinical diagnostic criteria, because they were the ones who did the majority of the work. They set out 3 criteria. The first is a clinical exam showing the characteristic swelling or mass effect, usually in single or multiple organs. It may be bilateral, may be unilateral, but in a classic place, having the right organ. Then having an elevated serum IgG4 level of greater than 135 milligrams per deciliter, which for those of you who can't do the math is basically 1.4 grams per liter. And then histology showing classic changes of lymphocytic and plasmacytic infiltrates with fibrosis. And then this elevated levels of IgG4 staining cells compared to the total IgG, greater than 40%, and an increased number of IgG4 cells greater than 10 per high-powered field. So it's not only enough to just have this increased ratio, you have to see a lot of them. You don't just want to see 18 cells or 20 cells and 60% of them are IgG4, but you don't see any in the entire biopsy anyplace else. You have to start wondering about that biopsy's value. What do we do with this is, if you have all 3, you have the disease. The disease itself centers mostly on the histology and exam, so if you have 1 and 3, It's probable, but if you really just have the masses and blood testing alone, the best you can say is this is possible. There are other specific organ-specific diagnostic criteria, which I'm not going to get into. They sort of change and they're not generally accepted. These are pretty much the ones that are felt to be useful in clinical practice. So you've made the diagnosis, you have the patient in front of you, you're comfortable with the disease. What do you do about the patient? Well, the first thing you have to do is, why did you make the diagnosis, and how did you make the diagnosis, and how is the patient being affected? There's a strong argument to say if the patient simply has some lacrimal swelling or some submandibular swelling, you may want to do nothing. That because the disease itself the problem is due to pressure effect and direct tumefactive effect, if they're not having any blockade of any significant structure, there is a real argument for just watchful waiting and making sure that nothing happens. On the other hand, if you have a more aggressive disease, sclerosing cholangitis, blockade of a major viscus, something else that is going to push you, you want to become more aggressive. Generally, we start with steroids. Corticosteroids seem to be very good. They're very good as initial responses, but as you can see by the numbers, although they're very good initially, their long-term responses are not great. When you give somebody the response, at 6 months, 32% of patients are better, but at 3 years, 32% of the patients have relapsed, and by 3 years, virtually all of them have relapsed. So in patients in whom you are concerned about the disease, concerned about the location or the organ system involved, using corticosteroids, you know you're going to have to use repeat courses, you're going to have all the toxicities of recurrent steroids, and if they have aggressive disease, you're probably going to have them do poorly. So instead, at this point, you would add immunosuppressives, and we use our standard regimen of immunosuppressives that we use. These are always the ones, whenever you see, for me, as soon as I see mycophenolate on a list, it's like seeing IVIG on a list. It means we're just throwing everything at these patients. So it's just whatever you think works, whatever you're comfortable with. Azathioprine, methotrexate, mycophenolate mofetil are certainly things that have been used and have been used effectively in some patients. But recent studies have shown that in patients who you're concerned about or have failed monotherapy, one of the things you could think about is B-cell depletion. I'll show you this. This was a poster that was at ACR this year from Dr. Stone and his group. They looked at 30 patients they got blood tests on 30 patients. They were only able to enroll 29 of these patients. These patients all met the biopsy criteria for igG4-related disease. They then treated these patients with 1,000 milligrams, 2 doses, standard rheumatoid arthritis dose with methylprednisolone, and set out as their primary income a decrease in their igG4 responder index. Think of that as simply a BVAS score, something very similar to the Birmingham vasculitis score, with a 2-point change being considered significant. They also wanted to have no flares before 6 months and have them totally off of steroids by the end of 6 months. When they followed these patients, they followed 26 of 28 for greater than 20. They followed 28 for greater than 1 month. 24 were out further than 3 months. And in fact, of the 23 patients who they were able to follow for at least 6 months, which was their primary endpoint, 20 of them had met their primary outcome, which basically is saying they had no use of steroids and had a good response with no flares and had virtually no evidence of disease or very little disease. Just as important, they did not have any serious side effects, so anything you would not want to see in these patients. So, brand new disease, relatively speaking, very exciting. I think we're all looking for this disease in our practice. I don't know we're finding it. I think we have to be very careful about overdiagnosing it, but this is something that is a rare cause of multisystem disease and something that should be in our mind whenever we see these patients with masses. This mass is the problem. So these are asymptomatic patients, and the problem is due to the mass effect. Keep that in mind when you're choosing therapies, because in patients who have mild disease, may have simply a cutaneous lesion like Rosai-Dorfman, your answer may be nothing. But if they are having inflammation or they're having the mass in a critical area, treatment should be very quick and very aggressive. The diagnosis is made not by blood testing alone, but by a combination of clinical symptoms, blood testing, and biopsy. When we treat effectively with our least toxic agents, but treat them as aggressively as necessary, and in patients who are having problems, DMARDs and now biologics, especially rituximab, are something that may be necessary. So, thank you for your time and attention, and I'll be happy to answer any questions, and we'll go from there.
All right. Thank you, Marty. Please, if you have questions, do come up to the microphone. Start Alvin, front left.
Marty, great talk. You mentioned a couple times Castleman's disease, which is an IL-6-driven disease. Are there any data with tocilizumab?
There is no data. There are no data that I could find. I shouldn't say there isn't. I didn't see anything in poster form, and I didn't see anything in my review. So if there may be somebody from some of the companies that are looking into this, I don't know of any. I don't know if any of the makers of IL-6 are looking into this. Okay.
Back left.
Thank you so much. So you talked about the role of the igG4 serum level that's not diagnostic for igG4-related disease, but what about for monitoring the response to the treatment, especially in the cases that we know that they already had a high level at the presentation?
There have been some people who have thought that you could monitor through that, although that's never really been studied. It's something you could consider, but again, not knowing the impact, whether it's causative or an innocent bystander, or even protective, I'm not sure what to do with that. So the answer is we don't know. I don't know that I would, although I don't know that I wouldn't either.
And my next question, in a patient that we cannot see the mass effect, for example, a patient with the aortitis or pancreatitis or like a retroperitoneal involvement, how often we should repeat the imaging? Every 6 months, every year to monitor the response to the treatment?
I think most people would say probably about every 6 months is what I saw in 1 or 2 of the articles I reviewed, just to see what they're doing. But again, if they're asymptomatic and they're not having blockade of any kind of organ system, it's just there, the question is we don't really know. I mean, unfortunately for a lot of the questions, I hate to fall behind that, but I think the answer is we don't really know. And I think that's the honest answer. I can make some things up for you if you want. But the answer is we really just don't know.
Front left.
Thanks for this interesting talk. One of the questions we have in treating this condition is what's the best way to monitor and what's the treatment target? You know, very often they don't have so many symptoms, and there's not so many biomarker to monitor. So very often, how do you define relapse and how do you define treatment response?
It's the million-dollar question, and the answer is symptoms. So if a patient is presenting with pancreatitis, you want to have them symptom-free from pancreatitis. How you define a relapse is going to be symptomatic, or the other would be a mass effect. So if you were to see the mass increasing inside rather than decreasing inside, which gets back to the other gentleman's question is, well, should we be getting imaging every 3 months, every 6 months, every other week? The answer is we simply don't know. There are no good markers. So this is going to be, what's your clinical sense? What fits the patient? Again, it's going to be very different. If the only thing that's there is a patient with swollen lymph nodes, and you biopsy it and it's not a lymphoma, you may not monitor them at all. You may just have them come in and you may just do an axillary exam on that patient. Patient who has pancreatitis, patient has aortitis, you might want to get an MRA on that patient frequently. So it's going to depend on location.
And just a quick one, what's the ideal dose you treat with the prednisone? Do you start with the same dose or you treat different?
The recommended dose is at least 0.4 milligram per kilo and as high as 1 milligram per kilo is the starting dose. Again, location, location, location. It depends on what you're treating. Patient has some sicca and some salivary swelling, you're going to go to a lower dose. Somebody's coming in with a rip-roaring pancreatitis, you're going to slap them silly with steroids.
Thank you.
Sir.
All right, front right.
Could I ask you some questions about the histology?
Sure.
You made a point about the heavy chain interchange. Presumably on the cells themselves, it's not having heavy chain interchange. Are those cells activated, and are they CD20 positive?
I don't know CD positive. I don't know that answer. I can look into that, but I would expect they are lymphocytes. They're plasma cells, so they are going to be CD20. So they're plasma cells, so they would have that And they are, I don't know their activation level.
So
I just
frequently they lose CD20 when they become
Right, when they
actual
come, when
plasma
they get,
cells.
right. When they get that high up, they're going to be less likely.
But you're getting a good response in these individuals. So the question is, are you treating precursors? Are they being activated and maturing? Or are you actually treating an intermediate cell that isn't obeying its normal signals?
And exactly, and your question is your point, is we don't know whether or not this is direct. Are these the cells that are involved, or are these cells that are actually trying to decrease an immune response? And we just don't know. This is a new enough disease that we don't know the answers. I mean, I'm not trying to be evasive here. I'm just
Back left?
For the staining on the biopsies, is it hard to get a pathologist to do the staining since it's a brand spanking new disease, or is it something we just request and they do it automatically?
Yeah, you should be able to request this with no trouble. This is something that they can do. The antibodies are commercially available. They should have no trouble getting them.
Yeah, it's easy enough for them to do. They just have not been requested to do it before this condition, but it's easy enough for them to do.
Yeah.
All right. Well, thank you very much, Dr. Bergman.